Okay, yeah, so this is recording now. Okay, so those of you who do not know me, I will introduce myself. So my name is Priyanka and I'm a PTEN researcher and I work on PHTS and I'm at UCL in London. I joined PTEN UKI as the research trustee and I'll be hosting the event today. And our guest today, our guest speaker, our expert today is Catherine. So Dr. Catherine Lachlan. Welcome, Catherine. Thanks for agreeing to speak to us. I'm sure pretty much everybody here knows about you. And, you know, but I would say you do not need an introduction. But yeah, Catherine, would you like to introduce yourself so that I don't miss out on anything?
So, hi everyone, I'm Catherine Lachlan. I'm a clinical geneticist based in Southampton. I'm the medical trustee for PTEN UKI. I'm just going to move my camera slightly so that you can see me properly. I don't know if any of you met me a long time ago. So when I was a registrar, so this is going back 20 years, I travelled around the country visiting people at home who had a PTEN diagnosis. And I met 42 people when I did that. So that was around about 2005-ish. And we published a paper after that. And I've carried on having an interest in this condition and how it affects people ever since. We've diagnosed quite a lot of people through the service in Southampton. We've been involved in writing guidelines and in setting up the charity. Yeah, I think that's probably me as quick as I can do.
So Catherine, just, you know, for somebody who doesn't know anything about PTEN, can you describe what it is?
Yeah. Shall I share a slide?
Yes, please. Yeah. If you have a presentation to share that.
I've got a few slides and I think that can help a bit. So let me see if I go on to slideshow on here. Current slide, because I'm starting halfway through. And then if I share my screen. Will it share the right screen? That's the question. I'm not such an expert on sharing on Zoom. Can you see anything?
Not yet, no.
Oh, okay, let me have another go. Oh, host disabled participant screen sharing.
Okay, I'm going to try and...
Okay, while you're doing that, I'll carry on.
Okay, I'll make you the host.
Oh, okay.
So now you should be able to share your screen.
There we go. There we go. Okay, so hopefully you can see that one now. So this is just a slide with lots of different issues that affect people with PTEN, and some of the things in big writing are the things that perhaps people have heard about the most. But there are lots and lots of different aspects to this condition. And we can't predict which ones will affect which people, which I think is one of the biggest challenges in terms of managing people. So if I let me go on to my next slide. No, it's not letting me move through the slides. Aha, there we go. Right.
This station is Finchley Central. Change here for train to Mill Hill East.
But I think that's okay. Yeah, muted.
So, PTEN hamartoma tumor syndrome encompasses all these different conditions. So I'll talk about Cowden and Banyan, Riley, Ruefel-Carber in a minute. Basically, what happened was that doctors described these different conditions. So geneticists like me and dermatologists and oncologists would see patients and they'd notice that sometimes some of their patients had lots of problems but had them in common with one another, and that might be running through a family or in people who were unrelated to one another, and that's how syndromes get described in the first place. So Cowden syndrome is really unusual because it's named after the patient with the condition rather than after one of the doctors, which is really unusual. Most doctors want the condition to be named after them. So I always rather like it that it's named after the patient instead. So she was a young woman. This is an old report now, so the language used in it isn't the language we would use to describe people anymore, but language and its use changes over time. So she had fibrocystic breast disease, so lumpy breasts, and she got breast cancer when she was young. She also had thyroid adenomas, so little benign growths in her thyroid. And when her mouth and her face were examined, she'd got little lesions within her mouth and on her face. She was described in the report as having borderline intelligence. And I think that's an old-fashioned way of saying that she had some learning difficulties, but actually I think she would have been able to have a normal conversation with us. And they described this as being an autosomal dominant inherited cancer syndrome, that it was rare. And most of the reports about Cowden syndrome actually came from dermatologists after that, because they were recognising the changes in people's skin, but also the association with particular cancers occurring. So that was really through adult medicine and adult patients and doctors who look after them. Banyan-Riley-Ruvalcaba syndrome, which is a real mouthful, and we tend to call it BRR if we talk about that now, was described by a really famous geneticist called Gorlin in 1989. And what he recognised was that several reports by geneticists describing these different issues in their patients all seemed to be in common. And so he brought those reports together under this one condition, and what he noticed was these very big head sizes, developmental delay, gut hamartomas, which just means benign, so non-cancerous growth in the bowel, thyroid disease as people got older. The developmental delay tended to be with motor problems, that there was pigmentation of the penis, but that's also been described of the genitalia in women as well, so sort of freckling, and also of lipomas, which are fatty lumps. They are not cancers, but they can be a bit uncomfortable depending when they occur, and they make people worried because they don't know what they are. And then this other condition, Lermity-Duclos disease. So this is named after French doctors, and this is a scan of someone's head. And so this part of the brain here on the scan is called the cerebellum. And then if you look at it at a different angle, so looking down through from the top of the head, you can see the cerebellum again. And it's this area here that's abnormal, and it's got this stripy appearance. It's sometimes described as tigroid. And again, this is a non-cancerous growth that happens in the brain. So it's not a cancer that spreads to other parts of the body, but it can grow there very slowly. And for some people, they have this and it doesn't cause them a lot of problems if they find out about it. It might just be monitored for quite a long time. But what it can do if it grows bigger, and once your soft spot has closed in your head, it can put extra pressure on the brain, and that's how it causes its problems. And so if people develop with things like walking or their balance, lots of people with PTEN have a bit of trouble with their balance, but it's when it's getting worse and it's a new problem, then we might think about this as being an issue and think about whether it does actually need any treatment. So I'm going to go back to that slide again, and just say there are some people who are described as having autism and are noticed to have big heads, and that comes under this description as well. And however you're diagnosed, whether it's with Cowden syndrome or with developmental delay or because of autism and a big head or because you've had been found to have Lermity-Duclos disease, all these things are encompassed under the one name now, and that's because we manage everybody the same, however they were described in the first place in terms. I'm going to stop there because I've talked quite a lot in response to quite a simple question, but I hope that helps explain it a bit for people.
Do you have more slides, or was that?
That's just, I've got lots of slides, but I thought I would put them up where it helped me answer a question rather than
Okay, so let's do this as a bit more interactive format. So I think you've explained really well, you know, what PHTS is, and you know, traditionally it was known by all of these names. And I think recently on the social media group, we've had somebody ask about the Lermity-Duclos disease, whether it is, you know, I think they have Cowden with Lermity-Duclos, and the question was, is it because of PTEN? And I guess it is. It falls under the umbrella term PHTS, isn't it? So that was one of the questions I had, actually.
So Lermity-Duclos, not everybody with Lermity-Duclos has PTEN, but if you have PTEN, then if you have Lermity-Duclos, it's because of the PTEN gene change, but we don't always find the cause of it in some people.
Okay. So maybe we can open up the questions to, you know, our audience as well. So if you have a question, if you could just raise your hand. I think it's the reaction emoji. Yeah, I've got a question from Wendy. Do you want to ask your question, Wendy?
This might be, I might have got this slightly wrong because I've been diagnosed for a while, but looking at your diagram, so my initial diagnosis is Cowden syndrome, but also macrocephaly. So where it sits on the diagram, is that just because they're all encompassed under one name? I know they're two different conditions. Sorry, I don't know if you know what my question is, but I've never seen them separated out before. I've always assumed that the Cowden syndrome and the macrocephaly were the same thing.
Yeah.
Am I completely wrong?
No, you're not at all. No, that's just how I'm explaining it, and I think I've confused you rather than helping you. So no, people with Cowden syndrome have big heads, and it's the most consistent thing across everybody in all of those groups. The vast majority of people with a PTEN gene change have a really big head. So it's part of all of those conditions.
Sorry, I'm having a poor memory day, so I thought I'll just double check. Thank you.
Okay, we've got a question from Laura.
Yes, let me just put my video back on. Yeah, hi. Can you hear me?
Yes.
Yeah. I've got a couple of questions actually. So my first question was, my son has got vascular malformations. That's actually how he ended up being diagnosed in the first place, because that was the first thing that was sort of identified. And he's got a big one on the side of his on tummy and one on his leg. And because he is severely autistic, oh, it's okay. I thought he was coming upstairs. Because he's severely autistic and he can't speak, I often wonder sometimes if he's crying and things, are they painful? And no one seems to be able to tell me if vascular malformations are painful.
I'm trying to think how best to answer that for you from my experience of people with vascular malformations. I think a lot of the time they're not.
I mean, I can touch them and he seems to be okay with me touching.
Yeah, and that's my experience of people with them as well. I think when they become, if they get very big, I think they can be uncomfortable.
And when they do get big, do you then remove them?
So that is the biggest challenge with the vascular malformations, because they tend to grow through all the different tissues and quite complex in how they grow. So they can be around, grow through nerves and have fatty areas within them. They can encompass other blood vessels, and so if you try and remove them, it's quite hard to
Mm,
you can't just take out an area because they're growing in and around other
yes.
they happen to be. So people use different ways. So interventional radiology, they might try and thrombose them to try and close off some of the blood vessels. And that can be successful. But if they're complicated, my experience is that people end up going back again and again.
Yeah, I think it is complicated. And
There have been trials of vascular malformations with medicines that can help, so things like sirolimus.
yes, they told me about that, but they didn't want to do it because of the side effects.
Okay. And it tends to be when the doctors have those discussions with people, it tends to be because it's reached a point where it's causing so much trouble that the side profile versus the problems that the malformation is starting to cause tips in.
Yes.
Yeah.
And is it normal that sometimes it looks bigger than another time? Do they sort of fill with blood and
Yeah, they can fluctuate.
Yeah.
While we're on the question of vascular malformations, there's a question from Sarah in the chat. How do you monitor AVMs? What do you look out for? What to look out for?
So I don't.
Sorry, what are ABMs?
Okay, I'll address that first. Thank you. You must say if we're using words that you don't know what they are, it's really important. So, and I'm particularly guilty of that because I forget that other people don't know. So yeah, please do just say. They're arteriovenous malformations. So it's where you've got blood vessels that are growing where they shouldn't grow. So growing between arteries and between veins and causing creating new links that shouldn't be there, and that can cause problems with the circulation, and they can get bigger and bigger. In some people, they stay very static and don't really change very much. They're quite unpredictable. So what do we look for? It depends where they are. It depends how big they are. It depends what symptoms they're causing. And my patients who've got troublesome ones tend to be followed up by the vascular surgeons or by interventional radiologists who look after them specifically. There is a group at Great Ormond Street that look after children with these. So I've had some patients I've referred up there to be looked after. And there is a clinic at St George's as well, but I know that these are looked after in lots of hospitals as well around the country, and that those teams are quite specialised and tend to talk to one another about how best to look after their patients.
So next we'll take a question from Sarah Jane.
Thank you. My question is in relation to hydrocephalus. So our daughter was born with she didn't have a particularly large head shape when she was born, but the circumference of her head grew very quickly, and they noticed that her ventricles were open and were filling with CS spinal fluid. So they intervened when she was 2 weeks old, corrected gestation with a VP shunt. And I was just wondering if and I can't remember now the name of the condition, because out of the ones that you had in that kind of circle diagram, we've heard of the Banyan one. Sorry, forgive me if I said that wrong. And cow, but the one with the brain tigeration or the stripiness, have you noticed in your research or in your experience with like young patients a consistency of hydrocephalus as well?
So I think they're two quite separate things. So I've had patients with hydrocephalus diagnosed very young as well with PTEN. So that does happen, but it's quite separate from Lermity-Duclos. So that's something that happens later on. It's very rare like really rare for children to be diagnosed with that.
Okay.
And so I think they would have seen it on a brain scan if it was there, but I really wouldn't expect to see it in a very little baby.
And I guess my question is kind of related, is can hydrocephalus turn into that condition, or they're different?
So
Okay.
you get hydrocephalus because of the Lemaitre-Duclos, because it can block the cerebrospinal fluid from circulating properly, but it's a very different cause to the type of hydrocephalus that you're describing in your daughter.
Okay. Thank you.
Can I just put in?
Yeah.
The LD will actually act like a tightening around the cord, around the spinal cord, and that's what could cause the blockage.
Yeah.
And it would show up on any scans as tigering. It's like mine is 14 millimeters, my brother's was 56.
Yeah.
I've got macrocephaly, my brother's got a 2-pound loaf tin for a head. There's two different conditions, macrocephaly and another one. I don't know what that one. I can't remember what that one was called.
Yeah. So there's lots of different causes of hydrocephalus. So that describes having excess fluid around the brain, but there are lots of different things that can cause it. But we do see it in babies, just as you were describing before, or as a secondary thing to Lemaitre-Duclos later on. But Lemaitre-Duclos doesn't always cause those problems. Sometimes it just is there and grows very slowly, if at all.
Kath, you've got a question for us? You mute. Would you unmute yourself, please? Thank you.
Sorry, two very quick questions, if I may. I've never heard of Lemaitre-Duclos before, or this striping. Both me and my mum have very poor balance, and it's probably gotten worse as we've gotten older. Is that something that we need to get checked out?
My experience of people with PTEN is that they often have quite poor balance, and I think we don't really understand why that is. I think it might be to do with the low muscle tone, but we don't really know. The things that would flag to me that someone needed some more investigations is if they went to the optician and the nerves at the back of the eye looked like they were under pressure. So that would be an important thing. So if your optic nerves look normal, then there's not likely to be something so urgent. I would mention it to the doctors checking you over, and I check people's reflexes and sensation in clinic. So I do a logical examination, and if I'm concerned, I ask for an MRI scan to look for it.
Okay. That's secondly, obviously this is a thing right across the family. My mum had renal cancer in her right kidney, and so did my brother. I've just sort of watched my mum go through a number of cancers. I wonder, is there any do you know how it's going to go in the family? Does it sort of, is it the same, or is it completely different in every single person, or I don't know.
That's a really, really good question. So no, we can't predict how it will affect different people in a family. And so we do the same screening for everybody. Occasionally, if there's one cancer that seems very prominent in one family, we might alter the screening for that particular family on the basis of the family history. But basically, we do the same screening for everybody because we can't differentiate at the moment.
Okay.
More often or less often.
Thank you.
Have you got the screening guidelines?
Yeah, I'm just in the process of going through that now. I've had discussions about hysterectomy and possible risk reducing breast surgery, and they're looking at kidney scans on a yearly basis currently.
That's right. So that's what we would do as well.
Yeah.
There's screening guidelines that we follow around the country. So that sounds like you've got the right advice, Claire.
Okay, thanks, Kath. We'll take a question from Randy now.
Hello, my son, he's 19. He was diagnosed with BRRS when he was 6 months. Obviously he has some issues, but one of the ones that I'm asking about today is, he has the development. I mentioned he has BRRS. And so he has a lot of the developmental delays. For the most part, he's pretty typical, but I would say he's like I said, he's 19. He operates probably more like I want to say 13, 14-year-old. And a lot of it is, of course, the attention, focusing, motor skills, executive function. His executive function is really very, very low. And so we do have him on medications, but I remember there was the trial a few years back of one of the medicines, and I think it operated on the mTOR pathway. And I'm wondering if he was in that trial, and ended up being on the placebo, it turned out. And so when we put him on the medicine, he wasn't able to continue because of some side effects. So I'm wondering if there's been any progress with that respect for people like him.
So I know this study that you're talking about that was run in the States. So no, there isn't an update on that at the moment. I'm sure there will be more studies in the future, but at the moment there isn't anything new in that regard since then. I know there's a lot of research going on into different medicines and trying different ones with different side effect profiles, but what's very hard in such a rare condition is doing a trial and being able to show that it's made enough difference to enough people and knowing what to measure to show how it's helped them as well. And that's one of the real challenges. How do you know if the medicines made you better or if you were slowly making progress anyway? And those are the challenges that they're difficult in rare conditions, and I think particularly difficult with this one.
Is there a recommendation for we do have professionals, of course, with his psychiatrists and therapists and all that helping out and helping him with medicine. We finally found a couple medicines that seem to be helping balancing things out for him, especially with some obsessive thoughts that he has going on. But I'm wondering if there's like any with others who have similar how would you say characteristics or issues, that there's certain medicines that seem to help out more than others in these kind of cases.
Not at the moment. Not at the moment. I'd really like it if there was, but there aren't at the moment.
Yeah, you and I both. I really feel for him. Thank you.
Okay, we'll take a question from Ganesh. There are lots of questions coming through in the chat, and we will get through all of them, but we'll take a question on the screen first from Ganesh.
Oh, hi, I'm Ganesh from Newport, Wales. My son has been diagnosed with juvenile polyposis. This is mainly due to PTEN and also BMPR1A genetic disorder. So he used to have lots of polyps. I think we were talking about around 500 polyps in 3 months duration. It was huge. So the lots of laparoscopic surgery had to undergo and the very young age, and also of course endoscopy and colonoscopy, polyp removal. Then he was on sirolimus from last 7 years. I think he is doing really good, but still he is developing polyps in his gastrointestinal tract. It's about 100 per year, which is comparatively manageable for a surgeon. So I just wanted to know how we need to prepare for his future And apart from sirolimus, I mean, similar question to Randy, is there anything going on in the research world which could help my son?
That's such a good question. There's a lot of work. I don't know if we've got PTEN Research going to do a talk at some point. It might be quite nice to ask them to do one for us in the future, because I think
I think they are going to do it.
yeah, that would be really good. So yeah, there's a lot of work going on to try and find drugs and to repurpose drugs that might help as well, that act in the mTOR pathway. But there isn't anything specific at the moment. My experience with polyps and there's a couple of groups in the UK that are really really skilled in polyposis, so St Mark's, and then there's Ho Mulig in Oxford as well. I don't know if you've come across them. So I think they make decisions when people are having, like we talked about with the AVMs, where they reach a point where it's becoming less manageable, where they will think about using other things. So I think it's possible there will be, but it's so rare. There's not a, it's not a medicine that you can say, oh, this is the next thing to try. But I'm really pleased that's made a difference managing things.
Of course, yes. I'm in touch with Oxford. Dr. Ulig is our point of contact, and he's guiding us. And he proposed two medicines, everolimus and sirolimus. So we started with sirolimus, and it was working really well for my son. We are continuing with that.
I think
Could I ask you what dose it is? Sirolimus
It's
dose that you're giving?
0.3 ml per day.
Okay, yeah.
It's a liquid.
Okay, just to sort of add, because Catherine mentioned PTEN Research, they're a research foundation, and they're funding a lot of research, around the world to exactly find therapies. And actually, I've been funded by them for this is my 8th year working at UCL, and all of my research is focused at repurposing existing drugs for PHTS therapy. So I do the preclinical side of things, and we've already tested six drugs, including sirolimus. And the idea is that hopefully we can bring some of these drugs to the clinic. So there is a lot of work going on, and let's hope some of these treatments do prove to be useful when they go to clinical trials, and we can eventually will be made available to patients. So it's not because there's not work going on, but yeah, it as Catherine said, it's a rare disease. It's very difficult to do something in a rare condition, but there's a lot of effort. And yeah, when we organize the talk from PTEN Foundation, you'll find out about all the efforts, because they are funding research and clinical trials, and they are really trying to find treatments for the different symptoms associated with PHTS. Okay.
Danesh, do you mind if we just ask you a question, sorry, about how old your son was, or like when you first kind of discovered the polyps, what were kind of the symptoms, or did you already have a PTEN diagnosis and it was through screening that you found the polyps with your son?
He was 6 months, and we started noticing blood in his poop. So that's where everything started. And it took around 3 months again to observe him, and finally decided go for endoscopy and colonoscopy. There they found lots of polyps. So in the local hospital, they said they cannot manage. Then I had to go to Sheffield. Professor Thompson is the one who did colonoscopy and endoscopy and removed all the polyps for the first time. Then it started growing in 3 months, and numbers were huge. So that's where then we found some research where this sirolimus was mentioned. So then we approached him with this research paper. Then he contacted Dr. Ulig from Oxford University. Finally, they decided they will go with this trial drug. And since then, now my son is at 8 year, so he's doing really well. But again, I would say he's having all the symptoms, I think, shown in the presentation. Like he has got a big head, he's got a development delay, but he's getting better year by year. And every year, if the numbers, if I look at, it's less than 100 roughly.
Sorry, can I butt in now? Ganesh, are you in South Wales?
Yes.
Contact the Swan Clinic
Okay.
in Cardiff. It's a Welsh thing. It's symptoms without a diagnosis. They may be able to help you.
Okay, I'll do that.
You'll have to Google it.
Yeah, I'll do that. Thank you very much.
Thanks.
Service in Cardiff. So the only other thing I would say about what Ganesh is talking about is that the BMPR1A gene is next to PTEN. And so if you have both of those missing, that makes it much more likely that a child will get lots and lots of polyps. For most of the children with PTEN, it's something that might happen, but isn't quite as predictable as when you've got both genes affected.
So yeah, so the reason we thank you, Ganesh, by the way, for sharing, but our daughter's also missing BRPR1A. We would say it wrong, but it's the same.
Yeah, okay. Yeah, we tend to think a bit more about doing the bowel screening if you've got both.
Yeah.
But I have had another patient who didn't have a lot of bowel polyps with BRPM1A missing as well, and I don't understand that variability. So I think until quite recently we thought it was predictable that you would get lots if you had both missing, but I have found another patient that has disproved that theory. So perhaps it's not as predictable as we thought.
Have you seen any case where after some age, the polyps are disappearing completely?
I haven't. I think Professor Ulik will be the person with the most experience of that. So I would very much defer to him on that question.
We are planning to have a Q&A session with him. I'm yet to organize a date, but clearly there seems to be a bit of an interest. So I'll reach out to him and we can organize a Q&A session with him. And his specialty is the GI polyp, so we can have a discussion about that. Okay, so I'm going to move on to some of the questions which have come through in the chat. The first the question I'm reading out is I hope I pronounce your name correct. Is it Yelena from Slovenia?
Yes, yes. Hello, it's correct.
Great. Yeah. So your question is about your son's thyroid nodules, and you said he had a lobectomy due to a big nodule that resulted that was benign before he obtained his PTEN diagnosis. Now he has another one in his remaining half of the thyroid. What would be the proper strategy to follow it up? For how long? And when should he have a surgery to remove the remaining thyroid if that's needed?
Really good questions, and a scenario that I've seen happen before. It depends on the size of the nodule in the other half of the thyroid. So generally, if it's under 1 centimetre, they will keep a single nodule under surveillance. It's when it gets bigger than that they'll start to think about either doing a aspiration to take some of the cells from it, so using a little needle that's put into the nodule, or they'll think about, particularly when you already have a PTEN diagnosis, they might start thinking about removing the thyroid at that stage. But there are people who have a nodule like this that stays the same for a very long time and they don't get any more. So there isn't a simple answer to say when to do the surgery. It depends what happens with that nodule.
Yes, it is still small. It is less than centimeter. It is 8 millimeters. But from the first case with first nodule, we learned that biopsy is not 100% sure, not even for papillary carcinoma, and it is 100% unsure for follicular, which is more related to Cowden. So I was just wondering, should we wait for it to become cancerous, or is it advised to remove it like preventive surgery? What is, I don't know. I don't find it anywhere in the guidelines. or in any recommendations. So I don't know what's the most common decision when it comes to larger than 1 centimeter.
So my experience of this is that these nodules don't always become cancerous. A lot of the nodules in PTEN are benign, they're not cancerous. It's if they're growing and changing that the thyroid doctors become more worried about them. And that's the thing that tends to prompt doing something with them. But for a lot of people, they stay the same and they don't become cancerous. The other thing I would say is that they don't change, they don't seem to change quickly into cancers. If they were changing quickly, the thyroid surgeons would jump and take out the other half of the thyroid very quickly, and they don't. And they're very used to watching nodules like this in lots of conditions. And I think that they have very good management protocols for watching these and deciding what to do.
Sorry.
I think it is influenced by how now you know the PTEN diagnosis though. So I think certainly in my patients, they've perhaps jumped towards taking the thyroid or the remaining thyroid out a bit sooner than they would have done if they hadn't known about that diagnosis in the background as well.
Yeah. So in general, your advice is to I mean, your experience would be to follow it just in like general population.
Yeah, that's what we've been doing. And I know that's what they do in the States as well. And I know that's what they do in the Netherlands too.
Okay. Thank you so much. It means a lot to hear it from an expert from this field, because in Slovenia, such a small country, there aren't really dedicated physicians, and it's very hard to come to the opinion of such an expert. Thanks a lot.
Right, and Slovenia is a beautiful country. I've been there lots of times. It's lovely.
That's true. When you come next time, please call.
Okay. So next we have a question about from Wendy about low muscle tone. So she's asking, what do you mean by low muscle tone, please? I've always had assumed my poor balance was my cavernoma.
I don't. So when we talk about low muscle tone, we tend to talk about it in babies and children, and it being part of what's contributing to the developmental delay, their motor delay in the early days. And actually, as people grow older, it becomes less noticeable, but it still seems to be there in the background. And it's just finding the muscles a bit, it's hard to describe. When you examine someone with it, they feel a bit floppier. It can manifest as a joint seeming a little bit more mobile than in other people. So I don't, it may be that the cavernoma is contributing, Wendy, but there may be other things contributing to that as well.
I was just curious because, you know, you mentioned reflexes, and I've had reflexes tested many times, and the doctors they say to me, no reflexes. And I'm like, well, I must have something. And they're like, nothing moves. So I was just curious, you know, sometimes you listen to these things, you think, oh, maybe that's going to pick up a piece of the puzzle for you. So that's fine.
It's having brisk reflexes that I worry about more than not being able.
Oh, really?
Yeah. So you saying that makes me think, okay, that makes me less worried.
That's fine.
Okay.
I'll take that.
Okay. Next question. Thanks, Wendy. Our next question is from Claire and Pete. They say that our daughter was diagnosed with, and I hope I get this correct, Kasabach-Merritt syndrome at birth, but not diagnosed with PTEN until she was 18. Is her birth diagnosis related to PTEN?
It might be, actually. So Kasabach-Merritt describes it's another sort of malformation of the blood vessels. So yeah, it may be tying it all together.
Okay. Wonder because no one ever put them together, and it took 18 years to get her PTEN diagnosis. When she was diagnosed with, she was literally 24 hours was old and Great Ormond Street diagnosed her with Cassavant-Merritt syndrome, and she had a massive vascular anomaly on her leg, but no one ever put it
together with the PTEN. To be honest, the vascular malformations and the PTEN link has come to light more recently.
Okay.
So it's made its way into the diagnostic criteria more firmly in more recent years. So I'm not that surprised that they didn't pick up on it. I don't know, how old is she now?
She's 19 and she got diagnosed last year. But she's been at Great Ormond Street since the day she was born.
Okay.
And we got diagnosed when they were kicking us out.
Okay. Yeah, I think it's I think there's just much more awareness of it, but actually the vascular malformation side of it, I think, has become much more recognised in recent years.
Okay, thank you.
Thank you. I've got a question in the chat from Liz, but Liz, you've raised your hand as well. Would you like to ask the question yourself?
Yeah, not actually Liz, it's Paul.
Oh, sorry. Okay. Hi, Paul.
I've met Catherine Lachlan before. I'm based in Southampton. My lad, he's now 12. He had half of his thyroid gland removed because it was heavily nodular, impacting on his trachea. His surgeon is saying that he should have the remaining half removed when he's 14. And I wondered why 14 is a key age.
I don't know why they would say 14 is a key age, Paul.
Okay. And my question I put in the chat, sorry, I didn't hear.
I'd be much more driven by whether it's causing symptoms or whether it's becoming more nodular than being fixated on a certain age. So
yeah, it is certainly growing. It's growing noticeably. We've got a follow-up appointment in a few months' time.
So if you're in Southampton, you know you're very welcome to involve me in that chat with the surgeons.
Yeah, I'll email. I will email you, as you've helped me out before, with a scan I had yesterday, as it happens. And thank you for doing that. But I wondered, I've got Salzmann's nodular degeneration. And again, the surgeons at the eye unit at the General have removed the nodules from my eyes. Is that linked to my Cowden's or just a lucky coincidence?
I would say we don't know. And I would say unless they, it might be worth us having a chat to them, but it may be worth them writing that up as a description, because that's how we find out about new associations. So two rare things, it's worth reporting that they've been seen in somebody with PTEN, and then perhaps we'll find that it is connected with time if someone else is described. And this is, you know, it's things like this when we say please join the registry, that actually that's one of the reasons we ask people to do that, because then we get better over time at finding out whether there are links or not with things like this. So.
And just one final question, if you don't mind, before I let you get on. I had a colonoscopy done the day after I was supposed to see you, as it happens. And as you know, you amused me in your letter when you said you had read my notes. Yeah. So I wondered, it was nodular, had a number of nodules removed for testing. I've not yet had those results back, and but I wondered, what is the official guidelines regarding scoping and colonoscopies and testing?
So let me, I'm whizzing back through my slides, and I am going to, let's share the screen, go on, there we go. Let's share screen 2 and go to from current slide. Here we go. So hopefully you can see that now.
It hasn't come up yet.
Come up yet. There you go.
Now it has. Yeah.
Actually, there you go. There was one more button to press. I said I wasn't good at Zoom. So these are our screening guidelines, and there's a nice leaflet that's available through the PTEN UKI website. So we suggest a screening baseline colonoscopy around between the ages of 35 to 40. And then we really rely on the doctors doing the scoping. Sometimes it's surgeons, sometimes it's gastroenterology teams, to decide on what follow-up's appropriate depending on what they find. So if it's completely normal, then they will say it doesn't need doing for a long time. If they are finding things, depending on what they find, they will make recommendations about how often to repeat it.
Okay, thank you.
Right.
Okay, so we've got a few more questions in the chat. So there's one question which is, what does sirolimus do? If you want to answer that, Catherine.
Oh, okay. So it acts in the mTOR pathway, and it essentially is stopping the cells from growing as fast. It's trying to slow down. PTEN's an overgrowth gene, and it's trying to slow down that growth pathway, and stop the cells growing as fast, and growing as big. That's probably the best explanation I can give for it.
Sorry, did you say mTOR pathway? What?
mTOR, M-T-O-R.
Okay, thank you.
Okay, so there is another question from Amanda. She says, my little girl was diagnosed with Cowden's last month. She has just turned 5. She has had several lipomas on both her hips removed in December 2023 and also has macrocephaly. This triggered our decision to get the genetics testing. Could I ask when screening should start and which screening is recommended? We have had initial consultation with the pediatrician and have an ultrasound next week on additional lumps, which have developed on her body. Other than this, she is developing as expected for a 5-year-old. We are very new to all of this, so any help and advice is hugely appreciated.
So in a 5-year-old, there isn't any screening recommended other than being checked medically. So we would go much more on what we find in a child and go from there. In terms of the screening for the cancer surveillance, that starts later. I know someone had put a message in the questions beforehand about why are the screening guidelines a bit different between different countries and with different timings, and that's because there's limited evidence about what's the best thing to do and when's the best time to start. And what you don't want to do when you're doing screening is cause harm, so psychological harm because of worry about going for scans, and the impact that has on people, but also by finding things that are not important. So you don't want to be screening and finding something that doesn't matter and raising anxiety or causing people to have some sort of intervention that might put them at risk. So deciding to do an operation that they didn't actually need would be one of the worst outcomes of screening. And so particularly for thyroid, there's a bit of debate in the literature at the moment about what's the right age to start. And so we're doing a survey at the moment of genetics and endocrine services around the UK to find out what's actually happening versus what the guidelines say, and also trying to find out whether when people have been doing screening earlier, if they found anything, and also have they seen patients or people with PTEN in childhood with thyroid problems, so that we can try and work out the best way to make this work in the NHS. And we're looking at trying to put together a programme or a screening programme or an update to the guidelines. And I don't know how that's going to work out at the moment, but it is something that we're looking at. So that's the only thing that would start any earlier. Everything else is from later on.
Okay. Just to add, Catherine, we did have quite a few questions sent in, and a lot of them are around the surveillance. And just so that everybody knows, Mark Tiskovich, he will be doing one of these Q&A sessions on the surveillance guidelines. If you have any more questions about that, hopefully we can answer it in that session. I can see that it's after 8. I have one last question that somebody sent in and they requested for it to be answered. She says, my husband and son have recently been diagnosed. I have an 8-year-old who appears to be unaffected at present if she does have PTEN. Is it recommended that siblings are also tested?
So it's important that we think about them, and then we think about whether to test them and when's the right time to test them. So that might depend on if you've got a very healthy sibling, seeing a geneticist and them saying, actually, there's no need to rush into this at the moment. They might measure their head. If they've got a big head, it might make you think it's a bit more likely that they've got it than not got it, and vice versa. But there isn't a right decision about that, other than saying we mustn't forget about them and we need to think about when to test. And that really depends on if they've got symptoms or not, what the right timing for that will be.
Okay. So do we have any more questions from the audience? I have a long list of questions, but maybe I'll ask them another time, Catherine. I should really let you go home because you're still at work. So
Mark will be really good at answering the questions about surveillance. So he helped write and led the European guidelines writing. So he really is a great person for all those questions to go to.
Yeah. Thanks everybody for attending. I, hope that you found this useful. And I think going forward, we are planning to have, more of these Q&A sessions with the experts. So probably what, we'll do is we'll put out a survey on our social media comms, just asking what topics do you want to be discussed? What sort of experts do you want? Because we think about it, but sometimes, you can give us the best suggestions. It's all about who you want to hear from, who do you want to ask your questions. So we'll do that. But this has been brilliant, and it's been very good to see everybody come for this, and I just hope that you found it interesting. And again, thank you very much, Catherine, for talking to us and answering all our questions. And yeah, I hope you can have a safe commute home. Thank you. Have a lovely evening, everybody. Thank you.
Thank you, everybody.
Thank you so much.
Thank you. Bye-bye.
Bye, guys.
Thanks very kindly. Take care, everybody.
Bye-bye.
Doc.